Hello, 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 everyone. This is your friend Baruti Carl Alexander, and it's Sunday once a month, and we are delving into our very important show that we don't talk about enough in the Black community, especially, and in society, period. Mental health. There are a lot of people have a stigma about it. They don't want to, hey, if you mention mental health, something must be wrong with you. So we're going to delve into it. We're going to talk about some of the crisis points that mental health professionals deal with. And I would like to introduce my guests. I would like them to introduce themselves. Sister Cassandra, can you start us off with the introduction?
Yes, my name is Cassandra Barnes. I am the owner of the Victoria Barnes Mental Health and Wellness Center, headquarters in Houston, Texas. I am a licensed psychotherapist, board certified in neuropsychotherapy. I'm also a registered nurse for almost 40 years, so I have combined experience about 40 years of healthcare, mental health management. And so I am very pleased to be a part of this amazing conversation tonight.
And as one of our frequent and most popular guests, we are so thrilled and blessed for you to be here. Thank you very much. Brother Christopher Times, can you introduce yourself?
Hello, I'm Christopher Times. I've got degrees in Bible, Christian leadership, and also Master of Arts in counseling. Uh, Practiced up in Virginia for several years and down in Harris County for several years. Worked with mental health cases. I still do that on a contract basis. Um, I'm working on getting my another credential, LCDC, an intern at the moment. So I got a test for that. But I've just got my hands in a lot of pots when it comes to mental health, and I work on the spiritual issue too. So I do spiritual counseling and also mental health counseling.
All right. Well, thank you very much. We're going to talk about, is there a difference also in spiritual and mental health, or are they all in the same thing? And how does that, come about? How does that, transition? Uh, Dr. Jaqueline Nelson,
Mm-hmm.
I got it right?
Jaqueline, yes.
Oh, blessings, blessings. Please introduce yourself.
Thank you. Thank you so much. Thank you for having me here this evening. I am a mental health psychotherapist. I've been doing that for decades. I have a doctoral degree in counseling, supervision, and education. My focus is on trauma and crisis. And my dissertation was on dissociations, of which many mental health professionals don't have enough education on. And so that's kind of my soapbox on that. I'm also a recent author. So I've just published my first book, and it is talking about trauma and how to deal with trauma. So I am glad to be here with this on this discussion. It is huge in the Black community and in every culture, actually. And so I'm very glad to be a part of this conversation.
Well, thank you very much. And I would like to talk to you first. I have had vicariously a lot of experience in mental health and association with it here in Texas. And I would say, overall, I think they do a great job considering you're dealing with somebody that has an issue managing their own mind and self. And considering that, and the world as a whole is very unforgiving in a lot of ways, and very much doesn't give the benefit of the doubt. I've tell a lived experience, and I've told it before. I have a son. I've been through things. My ex has been through things, and we have been through the system, and I feel very good that we have a system here in Texas that has been able to help us and work with us. Is that your same experience, or what have you seen differently?
Well, we're getting there, right? And I've worked with the education system in terms of preparing our mental health professionals. That was my research. The universities are not teaching the things that they really do need to teach. It's too general, not specific enough in detail, especially in trauma and dissociations, hallucinations, things of that nature. And we do have that. So we are doing good, right? It's not bad, but it's not good enough. And so with the research that I've done over the last 7 years has shown that mental health professionals are now doing what we call cherry picking, meaning they decide, oh, I can't deal with dissociations. I only want to deal with depression. Oh no, I can't deal with, bipolar. I can only deal with grief. So we can't do that. We need to be equipped so that we can deal with whatever comes in the room. Right, from an educational perspective. And of course, with mental health professionals, we not only just bring in our education, we bring in our experience from our past. We bring in, and I have to say, I'm a PK, so when it comes to the Holy Ghost and to the spiritual part, I don't do my work without God. I don't do it without Him. Yes, I have the education, but there are many times the words just are not enough. Things that we learn in a book is not enough to help people who are struggling. You're going to have something profound to tell someone. We can't just walk away with, okay, well, do your self-care, do some hobbies, do some affirmations every morning. It's not enough. We really need to be equipped. And I'm not saying that every mental health professional needs to come from a spiritual place. I don't know how you do it without him. So yes, we're doing good. I'm not saying it's bad. It's not good enough. And so my whole dissertation, my whole research, and I looked at the different colleges and our professionals, our mental health professionals are coming into practice not equipped. And so that's my soapbox. Of course, many people are going to say, well, no, they're very, very intelligent. Yes, they are. But we're dealing with not just mental health issues. We're dealing with hallucinations, demons, spirits. We're dealing with a lot that comes in the room. And if you're not equipped with that, you won't know how to handle that. And so let me just say this, and I don't want to take up too much time. There are many times I have someone that's facing you and they're saying, I want to die. I want to die right now. You're going to need something profound to say. And there are many times I tell my friends all the time, I don't want to say something from a textbook, and I want something profound. And God really does give me what to say in that moment. I don't know it. I mean, it literally is coming out in the moment. So I don't even know what I'm going to say. And it's just really powerful. So I'm not saying you can teach that in a school, because that's something different. That comes from God, right? So yes. So back to your question. Yes, we're doing good. We're providing mental health. I mean, it's just everywhere now. We've got companies with thousands and thousands of mental health professionals working for these different companies, providing mental health. Back in the day when I started, you didn't have ThriveWorks and BetterHelp and all of these big conglomerates. You just had therapists out here doing the work, trying to help individuals. So yes, it's accessible. I just don't think it's good enough. Because we still are losing people. It's a revolving door. People come in and saying all the time, well, they can't help me. It didn't help, and I'm still hurting. And the other thing too with mental health, it is not all the therapists, because people that just because you're ready, you need therapy, or you're not ready for therapy. In other words, you've got to come with a mindset to work, because therapy is not like going to the doctor. You can go to the doctor if your arm is broke. There is a remedy for that. They'll put a cast on it, and in time, it will heal. The mind doesn't do that. As much as people say time will heal all wounds, not when it comes to the mind, because people will not heal properly. People throw things into their subconscious. And what I'm concerned about as a mental health professional is that it can be triggered anytime. People are okay until they're not okay. So it can be triggered 10 years from now. You can be okay and something triggers you from your past, and it will be as if you're living in that moment. And that's the fear I have and concern for the individuals out here, because then you won't be able to handle it. When we talk about suicide and why a person wants to die in the moment, they are triggered by something. And most of the time they say it's something that happened years ago and they thought they were over it. And so I'm concerned about people healing from their past so that we don't have these things that will happen. We have people in therapy that are 80, 90 years old. You shouldn't be in here in therapy at 80 or 90. You should be living a wonderful life or in retirement, but they're dealing with things that happened when they were 20 or 25. So you really want to be able to help people, not just generally, but specifically and detailed, so that when they leave therapy, they don't have to come back to therapy in 2 years. So I'm sorry, I didn't mean to take over the show. I'm sorry, you asked the question. Yes,
that is okay. And I'm gonna come back because I still have areas to talk about in the mental health realm in Texas, especially. That's all I know because I haven't seen mental health anywhere else. Is that your experience similar to hers, Brother Times?
Yes, absolutely. And I graduated from Eastern Mennonite University in Virginia, and the quality of education for therapists on the East Coast far different from what you find in Texas, or in other places. I would say that my program was K-Prep. There are no K-Prep programs in Texas except for one that I know of. But we were prepared intensely. And the beautiful thing about my education was we were general in certain areas, but we were allowed to specify in certain areas that we wanted to practice in. And so I became a trauma therapist in grad school, and I wrote my thesis on childhood sexual trauma, and the various outcomes and possibilities for that. Very little research done on that, actually. And I love that dissociation piece because there's actually very little research with regard to that. And there are very, very, very few qualified clinicians who are even able to approach that. I've got a glimpse of it. I had one professor who was actually very well read on the matter and made it a part of his practice, but that's one out of like 5 or 6, professors who all were very gifted by it. So there's some lacking there. I've got a very little bit of education, but honestly, I could use a lot more, and I'm sure that we all could use more. And there's something else I know, Rudy, we hadn't mentioned yet, but in Texas, we don't have a system to staff cases. There are cases that we staff in Virginia at the university, even when we were practicing after grad school and after licensure and all. We were able to sit in staff cases with our professors, with other mental health professionals, face to face, using best practices. And when I come to Texas, it's crickets. And so that's so it's a lot. We got a few tools here in Texas, but we're lacking quite a bit. That's just my experience anyway.
Okay, I understand that perspective. Of course, I don't have a perspective outside of Texas, but I have been to Tyler. Not me personally, but family member been to Tyler. Of course, here in Houston and all around in Houston. So I've seen the mental health apparatus, how it operates here in Texas, and I'm kind of thankful for it. I must say that. I want to introduce Counselor Jennifer Cain, good friend of mine, and Miss Jennifer, we are talking about, as I mentioned, mental health in Texas. We are evaluating it, and I'm saying I'm thankful for what they have provided for myself and my family. And I was just sharing with everybody that, and everybody was giving their comments back. Before I get to you, I want to talk to Cassandra and have her address that issue. What do you think about the mental health in Texas?
Okay, hi. Well, I'm like Mr. Times. I did my master's in Virginia. My school was accredited Liberty University, which gave us both a secular and a theological perspective. I'm not sure where he went to school, but I had a very, very good experience because I am a strong Christian believer, and I too believe in holistically looking at every aspect of the person. Me being an RN, I always look at, medical, mental, spiritual, all of it. As I was working on my master's, I traveled. I was working as a nurse, however, but I traveled around the country specifically so that I could see how other university systems and mental health departments were managing their mental health issues. And I did contracts with the VA and other university systems around the country. And I actually felt Texas was better than almost everybody else. And I went to not Virginia, Connecticut, Colorado, Arizona, um, several different places around the country. For 3 years, I traveled while I was working on my master's. Even though I was working as an RN, I was always in the meetings with the therapist, obviously, and the psychiatrist. So I came from University of Texas, which is aggressive in the way that they treat mental health. I work for Harris County Psychiatric Center, which is the hospital associated with University of Texas here. And so my experience has been in those major systems. So I don't have a point of reference outside of that. The VA, various university systems around the country, and then into my private practice once I retire from nursing. I do think that mental health in general has come a long way only because of COVID and so much mental illness proliferation during the COVID crisis that sparked huge leaps and bounds related to mental health management, awareness, education, things of that nature. So from that, I don't personally have a point of reference prior to that because I worked as a nurse up until that point that I launched my practice, and then I only worked for a couple of agencies before going into private practice. But I can say that where we are going nationally, I think is amazing. Me being able to practice in many states across the country during COVID, as well as over 20 countries around the world. I was able to practice as a result of COVID not being restricted to Texas. And that was an amazing experience because what I was able to determine was no matter what country or religious background or belief system, people are just still people. It doesn't matter at the end of the day. I am a Christian believer. However, probably 98% of my clients don't ascribe to be Christian. So, and then I'm certified as well to be ethically correct. You can't implement biblical or any spiritual entity into your sessions unless you're credentialed to do so. So I'm licensed as an ordained minister. I am not a preacher, but I hold a license as an ordained minister, which gives me credentials in Texas to implement, as well as I'm a certified Christian counselor. So I say this as Jackie Dr. Nelson spoke about earlier, even if I can't speak the name of Jesus or make reference to God in any way, he counsels my clients through me, literally. And I know that that's why my numbers and my reviews are pretty much 5-star across the board. 4.8s, maybe a few 4.9s, but I'm generally 5-star survey, because he literally counsels my clients. Every morning I ask him and I invoke him, whether I can speak his name or not. He knows every person. He knows them from the inside out. He gives them what they need. When she talked about dissociative personality, I have a young girl who has, I think, 3 or 4 personalities. Each one of them have their own distinct name and personality. And
Let
she
me
has,
interject this, Cassandra. You say you have a personal relationship with, if I'm understanding, with God, that you utilize with every client.
yes.
Are every client receptive to that, or do you have clients that are not receptive to that?
Well, they don't know. 98% of my clients are not Christians, nor do they even profess to believe in God anyway. So I don't have to specifically say that. Okay. But because of my anointing and my relationship with God, whether I don't care what their religious belief system is, I don't care where they come from, they can be atheist, agnostic, they can be spiritual. That's the new buzzword now, that indescript. It doesn't matter, because of my relationship with him, and he knows them, he counsels them through me. I don't ever have to invoke him specifically unless they want it and they give me permission. I cannot even ethically introduce spiritual concepts into my sessions unless they request it.
I understand, Cassandra. That's an interesting approach. Mm-hmm. Let me ask Counselor Jennifer Cain, what is your perspective of the Texas mental health area, as well as I have a list of mental health crises. I was surprised that not sleeping and eating was listed among there. Can you talk about what you believe is the evaluation of Texas, and then talk to that somebody not sleeping and not eating and that being a crisis?
Okay, so Texas. All of my work in education primarily has been through Texas. I think that we are a little bit more progressive, I think due to the size of the state, than other states like Louisiana, who I was disturbed to find you have to go to the coroner to get mental health care in crisis. So I think that we do have like mental health deputies that'll come out to your home, the Harris Center for Mental Health, where, if you are indigent and financially having difficulties, you can get support there, and then they'll provide services within your home. And that also extends to IDD, intellectual deficiencies and disorders. There's a lot of range of addressing mental health in all aspects in regards to the system that we have. I've worked for the Harris Center. I've worked for the Harris County Probation, dealing with substance abuse and criminal behavior. I was present during the crisis of the Santa Fe shooting and provided support during that. And that was disorganized, to say the least, because it was something that we hadn't experienced in our state before, because the other tragedies happened after that one. But I think that there is some training that's necessary in regards to crisis intervention and how to address those instances in the moment when that happens. We were on a team addressing Hurricane Harvey. I was working for that program, and that's a crisis as well, natural disasters, which we have a lot of those in this area. We just had a few, actually, a month or two ago. So yeah, that is something that I think we're working on, but we still are ahead in a lot compared to a lot of other states, for sure. In regards to you saying insomnia and
Somebody not eating and not sleeping for several days.
that's a
And that was listed as a mental health crisis. I was very surprised by that.
Well, I think that is the effects of enduring a crisis, right? Like depressive and anxious symptoms, the body stress response, the HPA axis, it starts after you experience something like that. Your regulatory system kicks in the high gear to protect you. What happens is your threat response system kicks in. You're not going to be more likely to relax enough because it's trying to protect you, to sleep, to eat. Your gut health is going to be affected because if you are responding to a crisis and you have to fight, fly, or flee or freeze, you have to also have enough energy to do that, and you can't be hungry and rested and digested. So what that sounds like to me is that they are referring to the symptoms of crisis and depression.
Which is probably trauma or something. Something happened to the person that, their mind is so worried they can't go to sleep, or they are so upset or something they can't eat.
Very much
would that be trauma is the problem?
Well, I mean, it could be crisis events, which are also trauma or traumatic, right? Or even stressful events. The world we live in now is stressful as I'll get out. You don't know, how much your food gonna cost. You don't know what the gas gonna cost, if your light bill gonna go up. It's so hot. Global warming is making the weather all crazy. We don't know what we're gonna get. And that doesn't feel safe. And so what your body's gonna do is respond to that. And that's your body stress response. And so you're going to have difficulties, eating and consuming. You will either eat more or less, with your gut, just producing acids to protect you. That your body is your protector. It's going to give you the things, but it's going to take away from other areas if you don't properly care for yourself and your wellness, take time to do certain things to manage the crises and the stress. Then it, we all know can kill you, honestly, if we don't address it. So these are normal responses in this chaotic world that we're living in right now, honestly.
Can you tell the audience who you are, introduce yourself? Everybody else had an opportunity, and can you do that for us?
Yes, I do apologize. I had some logging difficulties, but I'm Jennifer Cain, owner of Adorn Counseling. Provide psychotherapeutic services. I have 2 other counselors that work with me, and we treat a range of difficulties, anxiety, trauma, stress, depression, things of that nature. I'm also an herbalist, newfound and very dedicated. So herbal medicine also is something that I am dedicated to because it's changed my life. So I am the owner of that practice, Adorn Counseling.
Well, thank you very much for being here, my friend. Thank you. Dr. Nelson, I wanted to ask you about that not eating and not sleeping. I'm trying to do a little fasting now, so there's times when I don't eat, and I'm trying to lose weight, and so it seems like a logical thing to me. But you're saying it could be a problem if somebody doesn't eat for 3 days. Now I can see not sleeping. If somebody, but wouldn't their body just naturally shut down, and they have to? I mean, they just can't stay up forever. Dr. Nelson?
Exactly. Thank you. And when you talk about fasting, though, that's a choice. You make a choice, a logical, methodical choice to do something. You prepare yourself for the fast. So this is totally different than being triggered. or being upset or a crisis or an emergency. So your body is going to respond differently. You're calm. You say, you know, for the next 3 days, I'm going to fast. I'm going to focus on reading. I'm going to focus on meditating or whatever you're going to do, right? Exercise, you know, whatever. But in a crisis, when someone is upset, when someone is triggered, when someone is surprised, scared, or frightened, the body responds a certain way. But again, as your other guest, I'm sorry, didn't get your name. I forgot your name. When we talk about the stress hormone, the body is going to protect you. If you're frightened, the trauma, the crisis, then the stress hormone is going to activate from your brain. So cortisol is going to course through your body. It's going to affect you. You're not going to think about eating because that is not what the brain is focusing on. It's focused on getting you out of the danger, whatever that danger is. So eating and sleeping is not going to be what you're focused on. And yes, it is a crisis because not sleeping, again, people fall asleep at night, but they're not sleeping. They only fall asleep because the body is exhausted. They go into a comatose state. But most people don't go into what we call REM, rapid eye movement sleep. That's deep, restful sleep. And what we found, scientists have found over the last 10 or 15 years, is most people living in this stressful world, they have cortisol coursing through their bodies all the time. So people are stressed and anxious constantly. It's like a norm, but it's harmful to your body. That hormone is harmful to your heart, your digestive system, right? So again, you know, it is a crisis. And so we do teach that, or we try to advise and guide individuals in how to calm yourself. Because if you don't calm yourself, the brain is just designed, the brain doesn't know the difference between you being upset because you had an argument with a friend, or if someone broke into your house with a gun. The brain doesn't know the difference. All it knows is your response to it. So once you respond to something with fear, anxiety, or worry, it kicks in. It says, I need to protect you. Let me give you this stress hormone so you can, as they say, fight or flee, right? That is all that's happening there. But in mental health, we have to learn how to calm ourselves. So you have to talk yourself down from that through breathing, meditating, focusing, internal dialogue. So you bring the emotion down. We've also shown on MRIs when an individual is focused on the emotion of fear, trauma, anxiety, anger, that is all the brain focuses on. So your frontal lobe, your executive function, it literally shuts down. And all the brain is focused on is the excitement, the trauma, the emotion, the feelings. And so people get overloaded with emotions and they do things usually that are harmful. And that's why people make the statement, oh my goodness, I didn't mean to say that. I was so upset. Well, that's true. I wasn't thinking, because you're not able to think clearly when your brain is overloaded with emotion or fear, worry. So yes, not sleeping is going to have a impact on your body, because the brain has to sleep. At night, it cleans out the trash. If you don't go into what we call the REM sleep, that deep sleep, the brain doesn't get the chance to do that. So you wake up the next morning with the same troubles from the day before. And some people wake up every day the same way. They never really get a chance to rest, and the brain never gets a chance to clean out the trash that's inundated into it each day. So it is a crisis. So not eating and not sleeping, some things I focus on even with my clients, we really talk about how are you eating. A lot of my clients, I do order a sleep study for them, because I need to know if you are really sleeping, if you are resting, because that's going to affect how well you do in therapy. People who are not sleeping and eating, they can't even focus on the homework that I give, because I give a lot of homework to my clients. They can't do that effectively because their bodies are in a traumatic state. It's not calm. It goes to bed traumatic, it wakes up traumatic, it stays in trauma all day long, and it's just a ripple effect. And it's really,
Just
really
a quick question on that. Isn't that an indication of, as I was asking earlier, a trauma, a stress that is the underlying factor as to why they're not sleeping and why they're not eating? And wouldn't that be the area to concentrate on?
Well, you got to concentrate on it all. But we've got to, in my practice, I focus on the emotion. We cannot really have a conversation. You cannot teach someone something or guide someone into, when we talk about mental health, if they're over emotional, we've got to talk about, how do I calm down? Okay, first, where did the trauma come from? That's the first focus. Where is it coming from? Because if we don't resolve that, it will keep coming. If we don't make sense of it, make peace with it, resolve it, whatever we have to do with the source of the trauma. If it's your mom, if it's your dog, if it's your job, we've got to work through that area so that it doesn't continue to re-traumatize over and over. So actually, it's a lot when we talk about mental health. Where it's coming from, the emotion that it's causing, how you're going to calm the emotion down, and then solve the problem. What happens is people try to solve the problem emotional. You have to come here to a somewhat neutral state so that you can handle the problem properly without over emotion. So it is a lot going on when we talk about someone dealing with trauma, emotions, trying to think clearly, trying to resolve issues, and trying to heal. It's a lot.
Yes, ma'am. That's very insightful. I didn't look at it like that and so forth. Brother Times, the same area about somebody not sleeping and eating, but I also want you to go into delusions and other aspects of hallucinations. I have a family member who talks to himself as another person. Now, if you talk to him and ask him a question as who he is, he can go out of that other person and answer you, but then he goes back into that other person. And I'm still trying to understand that. So talk about both of those things, if you would.
Sure. One of the things that I always ask my clients every time I talk to them is about sleep. How's your sleep? That's a good, like a medical doctor will, check your pulse and your blood pressure. Well, for clinicians, the sleep piece does a lot of that for us because we're able to really diagnose or try to get at a substance. What is really driving this behavior, right? If you want to go Freud with it, what's the drive? What is driving this behavior? Because there's always something that drives it. So is it a trauma? Could be, maybe not. Is it just, some chemical imbalance, some neurological damage? Could be, maybe not. Could it be, it could be anything. And so you have to really be kind of like Dr. Spock when you're dealing with patients because, they don't know what's going on. And so we as clinicians have to really kind of play doc with them and kind of do some investigation through systematic questioning, right? And proper, and this is a big deal, proper and adequate diagnoses. I come from the school of thought and I practice it. You can't adequately diagnose on the first visit. It's not possible. You have to really go 2, 3, 4 sessions or more before you can really actually come to a real diagnosis. Let me give you an example of what I mean. I just had a patient last week, 62 years old, educator. Okay.
That sounds like
Loaded
me.
with, right. Loaded with medication. Loaded with medication. A part of my assessment every time I have a session is I go over medication. I'm certified in that step too. So I go over medication. What are you taking? I'm tracking what the doctor's doing. Okay. And so I go through all of these things, the sleep piece. I told one of my other patients the other day, you need to go get a sleep study done. All of these things, because see, psychoses can occur depending on what's going on. There's a term we use called comorbidity. It sounds weird, but certain things can be medical and certain things can be psychological. We don't talk about that often, and a lot of therapists aren't trained well when it comes to that. And I will go as far as to say I know several psychiatrists who aren't very good at this. And so there's a comorbidity. You've got to rule out things in order in order for you to be able to rule in things. You see, that takes time. It's methodical, and you can't discuss that with your patient, by the way, because they're not going to understand it. You might run them off. You know, they're already in fight, flight, freeze mode when they come see you. You see, so you've got to do a lot of work. But once you get there, I'll give you an example. I had a patient of mine down here who had been going through psychosis since 2011. Okay. Recently, I just got him in with the local MRA down here. This guy wouldn't even take pills, no kind of medication. He's psychotic. TV was talking to him. The cameras were talking to his parent and installed cameras all in the house because she didn't know what he was going to do from minute to minute. This guy's 32 years old, been living like this for years. Guess what? I found out just by doing this type of diagnostic questioning I'm telling you about. I found out he had 2 TBIs within a 2-year period of time on the onset of the behavior. Nobody else has been able to figure that out. You see what I'm saying? And I had a patient just the other day, same thing, the 62-year-old teacher. So there's a lot goes on, but there's no simple answer to the question. I guess that's where I'm getting to. So you got to do a lot of investigation. I don't know what you all think about it, but I've noticed a lot of other mental health professionals. Let me be more specific in saying psychiatrists and other medical doctors. They tend to not respond to my requests from an ROI. I don't know what y'all think, but that's what I've been getting. And it's frustrating because when I send out an ROI and have my patient sign it, and I send it to whoever, I need to talk to them because I'm noticing some things that they're not noticing. They're signing medications. I'm sorry, soapbox. They're just pill pushers. You know what I mean? So they're pushing the dope, they're pushing the pills, and I got patients that really don't need that stuff. No, there's some other things we can use. So I do a lot of psycho ed also with what I do. I'm talking too much. So yeah, that's what I got for you, Baruti. And you pass the torch. I can talk all night on that.
I got you, and I understand what you're saying about the medication. The person I was talking about. They were on Haldol at one time. Then they were taken off. Then they were put back on, and found out they didn't need all that stuff. But when you go to so many different doctors, and if you're in the system a long time, different people have different opinions as to how to do this. The mind is a very complex thing, and there's no just one way that somebody can be treated. So that's why it's so good to have these conversations. It's so important. Sister Jennifer, I want to ask you, again, this particular person has delusions, hallucinations, as I was saying, talks to himself, but if you talk to him, he can give you an answer, but then he goes back to talking to himself as another person. And I think it came about because he was so involved with Instagram and talking to people on the game that he developed another character, and he used to talk to people on the game, and then even though the game was not on, he would still talk to them. How can I relate to him?
So I want to make sure I understand the question. Are you asking me how you can communicate with him?
How to do what?
Are you asking me how to communicate with him?
How to understand where he's coming from. I think I'm doing as well as I can. But
you might, but some things of that nature may not be understood, but he might need that support no matter what, right? The human connection is the biggest healer, I think. And
Say
I mean,
again?
you can't hear me? Let me see. Is better? Can you hear
Maybe
me?
so.
You don't know. Okay. I said human connection and support is the biggest healer. That's why therapy works, if you're willing to
Okay.
do the work, right? Like being understood and related to and heard is the beginning of healing.
So basically, maybe if he can be sustained over time with support, that's the best possible strategy.
I think that's a great start. I'm saying
Okay.
you're having conversations, not talking to whatever you think his illness is, but just making sure you're gaining an understanding of how he can feel loved and heard. That's it. Because a lot of the times, he could definitely have some mental health things going on. He can have some physical health things going on. It could be a combination of the two.
He's
Most
been
things.
diagnosed as paranoid schizophrenia.
Okay. It could be all of those things. But again, having a safe space to be able to be heard in that. And that sounds like you care enough because you're asking all of us to be able to do that for him will help either guide him to get the help that he needs or just for him to feel good enough.
Have you came across clients with hallucinations and delusions?
I have quite a few. Usually they're trauma-based.
How do you deal with those type of crises?
Well, usually it's trying to understand the root of it for me, right? I understand the root, and then I make sure that I support the client with daily activities that keep them healthy. So like I don't know, the doctor said, I'm not sure her name. We got to get these names together. But she was saying how it's important the sleep aspects, so all of the things that we do, what we're consuming, because what we put in our bodies impact how our brains work and how we function, our energy, all of those things. If we get those things regulated, how we practice self-care, if we take care of ourselves, because we live in a stress-driven country, then if we can address those things first and then manage whatever, like get a deep understanding of the medications also, right? Like, because most of my clients see doctors, psychiatrists that are highly medicating them, and they don't regularly do it because they're self-medicating because that is quicker. And then that causes the hallucinations, the depression, all these other things to intensify, right? So we have to find ways that can manage those things. And also, I just hear them without judgment. That is the most, like I said, the most healing thing. But yeah, there are ups and downs. They have their moments, but it's never I haven't had a client that had some detrimental outcomes because of being heard and having a space to be heard. Now they're not treating and taking care of themselves and self-medicating. Yeah, they have some issues. But other than that, I think that's the greatest thing that we can do for anybody, and teach them how to care for themselves holistically, for sure.
Understood. Cassandra, delusions and hallucinations. How do you deal with somebody with delusions and hallucinations?
Okay. So I'm a registered nurse and a licensed psychotherapist. So my position is probably very different from Ms. Cain's related to that, because we treat it medically. I get, what she's saying, but when you have somebody that's definitely disassociation, him seeing himself and talking to another person, that's disassociation. That's where the brain has compartmentalized, for easier way to say it, two different aspects of who he is. So this person is literally looking at a part of himself as a whole separate individual. So it's difficult in that generally when we've treated patients that were psychotic, that have delusions, hallucinations, things of that nature, I don't know how you treat it without medication management. When I was at Harris County Psychiatric Center, me and one of the psychiatrists, which actually was a reason that I did a part of my thesis on it, he didn't feel that any mental illness should be treated with medications, that at the root cause of every mental illness was some level of trauma, and also the spiritual component, which he feels, and I do too, that every illness, be it physical or mental, is driven by a spirit. He was from Africa. He had a lot of involvement with spirituality and things of that nature. So he was very into that aspect of driving the drivers for mental illness. So I think when you're dealing with somebody with dissociative personalities where they're seeing themselves as two totally different people, it's gonna require a little bit more than that, not to contradict what she said. But that's a significant mental illness. It's not just lack of validation or feeling hurt and things of that nature. For the most part, it's true mental illness, and that level of mental illness we had to treat with medications. But I do believe, and it's debatable, when you have actual psychotic breaks, which is what it seems like he has had. An actual psychotic break is what we call that, where you have schizophrenia and various levels of schizophrenia. It is a lot more difficult, and to be honest with you, those levels of mental illness are generally going to be lifelong mental illness. Even as we diagnose mental illness, your mental illness diseases are lifelong diseases. They never go away off of your medical record. As a corporate administrator, this is what I dealt with in a nursing space, but it's still the same thing. So these are actual lifelong mental illness. At best, you want to manage it. Generally, that's going to require medications. Therapy has not been very effective long-term. You're dealing with people that have schizophrenia and issues where they have actual psychotic breaks like that. And it's just mainly management. I've dealt with some of the worst psychiatric diagnoses as a RN, definitely severely traumatized patients that I would see that behavior many times. I was working inpatient a lot when I was working with that population. I don't actually have patients or clients in my practice that are psychiatrically mentally ill like that, because therapy is not very effective with those levels of mental illness. So those do require medical management for the most part. If you can get them balanced out enough, maybe some therapy may help. But when you have that level of psychotic break, generally therapy is not going to be as effective because of the root cause of what's actually happening when you have a break like that.
Let me ask this. Let me make sure I understand. Are you saying that somebody with a level of schizophrenia, paranoid schizophrenia, cannot be healed, or are you saying just always be on their record?
I will not ever say that they cannot be healed, because I'm a strong Christian believer, and I believe that every disease process can be healed spiritually. Okay, but I'm talking about what you're generally gonna see if there's not a spiritual intervention or something to that magnitude. We had, when you're dealing with schizophrenias, paranoid affective disorders, those levels of schizophrenias are lifelong diagnoses. There is a brain chemical alteration, generally as a result of some level of trauma that has occurred, that's reconfigured the brain. And I don't want to get real technical with a lot of that brain chemistry alterations and brain structure alterations. I am board certified in neuropsychotherapy, so I've done quite a bit of study in this area, but I don't want to get too technical with that. But just keeping it basic for this platform, when you have diagnoses that are true mental illness, such as certain manic depressive bipolar disorders that are really psychotic at the root, schizophrenias, those types of disorders, those are lifelong diagnoses where you have had a psychotic break.
But
In many
okay,
cases,
you're saying the person had a psychotic break, because I know for a fact that the person wasn't always like they are now. So
right.
You're saying that traumatic event caused the break and reconfigured the mind, and he can't have a psychotic break to change his mental state?
I'm not saying, I would never say what a person cannot do. That's not even, I'm saying what is generally the case. So when you're looking at, so let me just explain really quick, because it can get very technical and I don't want to get too technical. When you're looking at a psychotic break for whatever reason, it doesn't have to be that a trauma happened in that moment, okay? You can, when you deal with subconscious mind programming, things can happen even in utero. Your subconscious mind starts forming at conception. So your subconscious mind is gonna be your operating system, just like you have an operating system in your iPhone or whatever. That subconscious mind programming drives 95% of how you operate in your life. So if you have an early trauma, you can have a trauma you don't even remember that you experienced. I have had clients that experienced a trauma before they were 1 year old, traumas that they didn't consciously remember. But at some point, depending on a progression or a trigger, because once your subconscious mind has a particular programming, it's programmed like that unless you do something to reprogram that aspect of your subconscious, which is how I work with my clients. So I work with them to heal areas in their subconscious that is contributing to how they show up in life in ways that they don't want to. So say you can have a client who in his mind, he had a wonderful life growing up. Something happened that he may not even connect to. We would have to, that's another show to look at subconscious mind formation, but they can be in college. You see it a lot with college age, especially young men, and something can happen and they have a psychotic break at that point. So in that instance, your brain is literally reconfigured. The brain chemistries are reconfigured. So once you have a psychotic break, you can heal, but most of the time, a psychotic break is a lifelong diagnosis. This is why when I was working in psychiatric medicine, we would have patients.
Cassandra, we are toward the end of our show, and I want to give everybody a chance to respond on this particular issue. If somebody has a diagnosis, can they be healed? Jennifer.
Yeah. Can you hear me?
We hear you.
Initially, I'm a little confused because I thought the question was how to support the person for Baruti to talk to him. I don't know how we got where we were at. first. I'm a little confused about that.
Well, I
But
mean, the question was,
That wasn't, yeah.
it came to, we were talking about somebody who has paranoid schizophrenia, and the statement was that that is probably a lifetime illness. Even though they didn't start out with that, they had trauma that happened that reconfigured their mind. It seems like if they were reconfigured once, they should be able to get reconfigured back, or at least in a functioning way. What has been your experience?
I know that we can address any mental health disorder if we take care of the whole body and mind, for sure. That is very much so true. I think it's always going to need management, but that is very much so true that it can be addressed. That doesn't mean that that person is going to be in the same place forever if they do work to manage every aspect of them holistically. I don't agree with that. But like I said, management. I can personally say I have type 1 diabetes. I actually had a seizure on Wednesday. My brain in those processes, getting older, stuff like that. Like I recall having when I do have the seizures because of low blood glucose. Our bodies and our brains need glucose to function. And I will have like a hallucination in that time. My brain is not forever damaged, but because of that, I need more recovery because I've experienced such, traumatic bodily, mental, brain injury, honestly, because I was seizing for quite a bit the other day. So now I have to recover, meaning I'm taking care of myself, making sure I'm mindful of what I'm eating. I have to rest. I can't overextend my body because if I don't, it can have even more long-term effects. That I can't say won't ever happen again. I've been having diabetes almost all my life. I can't do anything about that, but I know that it does impact my brain and it doesn't impact it in a way that my cognitions are. I'm having psychotic breaks in that moment or anything like that, but I am having hallucinations because the chemicals in my brain are distorted. They're not, I don't have the glucose to help it function. So in that space, I know personally, and I know what it feels like as, having a psychosis in a moment because of that. And so I can connect with my clients in a different way. And I understand that when you experience something like that, it's not the same thing, right? It's not exactly the same thing. But if I can say I understand what you're feeling and you're experiencing, and have you tried this? And maybe you should, adjust this, or talk to your doctor about this, or, these different things. I know that they can be managed so that it happens less often. I know that for sure. And I know that, oh, go ahead. What you about to ask?
I was just going to say, your experience as a mental health professional, and blessings, by the way, in your medical situation, but your experience as a mental health professional put you in another frame of thought so that you know how to handle it in the best way possible. Not everybody has that,
but
realm. But
no, but you know what? What we put in our bodies and giving it enough rest is the feeling things that we can do with it. Period. I mean, that's where you can start. Recovery starts with rest. You got to get enough sleep so that your body can, like the doctor said, recover. Your brain can recover and get all that trash out. And so that's what I've been doing. I still been on the struggle bus, but I'm saying all that to say, I understand what that looks like. I understand what it feels like. And I know that you can make efforts to get through it. I'm not saying that you don't need medication. I'm saying that all holistically, addressing all areas can heal you holistically and long-term.
Yes, blessing. Thank you very much. Brother Time, do you have a comment on that?
Oh, wow. Yeah. Schizophrenia is very interesting. It can be induced via trauma. We know that that's possible a lot of times, more than not. It can also be a chemical. Case in point, you can get a bad blunt and have psychosis from
What'd you
that.
say, a bad blunt?
Mhm.
Yeah. Oh yeah,
Okay.
absolutely. Marijuana is known, one of its uh, lesser known qualities. It can induce sustained
They say
psychosis.
it has medicinal qualities.
Yeah, but it's a
Well,
hallucination.
it's a hallucinogen, and I let me give an example. When I first came back to Houston, I was working in a psychiatric ward. There's a 21-year-old that lived in Fifth Ward, ended up on my unit. He was standing on the side of his bed, crouching, flapping his wings at 5 a.m., crowing like a chicken. The reason why he was doing that is because he got some bad marijuana. And looking at his file, he'd gotten that years before that. So at 21, he was still psychotic from the first onset. And it wasn't, you can get psychosis, schizophrenia also through genetics. Um, you can get it from genetics. A lot of times through your mitochondrial side, and you can get it that way. So there's no one shot, answer, no simple answer to this question, right? But basically schizophrenia. Now the piece about can it be cured? Wow, that's a hot potato. I always lean towards medication as a way to manage. You see, and so now I do have I have had I used to work for the Harris Center for years too. I have had clients that have schizophrenia and you would never know it, because they do very well. So that's the other piece that we hadn't even talked about.
Managing.
Schizophrenia is not it's not the same for everybody who has that diagnosis. That's just one thing we hadn't really ever touched on. But in this discussion right here, but schizophrenia has many different manifestations, right? And so, just because you have schizophrenia, it doesn't mean that, you are completely psychotic all the time. It doesn't mean that at all. But it could. You, you see what I'm saying? So, it's just a lots of different things there. Very interesting how to treat that. I think body, mind, spirit is the way I always go in treating that piece. I think you need all three. And the part of the body piece is the medication part. And so, so there's just lots of things there to look at with schizophrenia, in particular. But I mean, you can get a TBI, okay, and end up with schizophrenia. You see what I'm saying?
Mm.
So there's not one iteration of it. There are lots of different iterations of that. Yeah.
Sounds like that's
There's
something
no,
that we probably need to have a whole show about.
you do because you can't treat, and you can say this about depression or anxiety and PTSD. We can talk about access to diagnoses. I mean, Brody, we can talk forever. You see what I'm saying? Because there's no such thing as this is how you treat this. That does not happen. It doesn't exist.
It is something. It is almost akin to autism in this way that it has so many different variations and different uh, kinds or different aspects to it that schizophrenia in one person looks totally different than schizophrenia in another person.
That's
I can
interesting.
I can I can have 20 patients in a room with schizophrenia and they all have different iterations, guaranteed, because they're not all the same. And that's why diagnoses is so important. And also treatment planning. We need to have a show on treatment planning because treatment planning goes closely hand in hand with proper. That's why you shouldn't ever rush to diagnose anybody. I used to give provisional diagnoses when I used to work in the ED up in Virginia, I worked for Centera Hospital, and I worked the ED at night and stuff, and I'd give provisional diagnoses and have people, basically TDO'd and all this stuff. But you know, yeah, a lot of times, and then we need to have a show just on diagnoses because a lot of the MDs and DOs and NPs and PAs will look at a
Well,
diagnosis.
Times, I'm gonna tell you, we're gonna continue, but we have to be at the end of our show now. We've been talking for quite a while. Can you give information on yourself, how people can reach you, whatever you like to share as your final statement, but also share your information.
You can just Google me, Christopher Times, MA. My information should pop up on Google, and I've got 5-star ratings too, just like he said. But yeah, you can pop that in, and my information, phone number, everything's in there. And I am located in Galveston Island, 2121 Market Street. That's where my office is, Galveston, Texas.
And I'm gonna come down and visit you real soon, my brother.
I got you.
All right. Sister Cassandra, can you share your last statement as well as give information on yourself?
Okay, yes, I'm Cassandra Barnes. I just want to be clear that I'm talking actual diagnosis of schizophrenia, not situational psychosis based on marijuana usage or injury things. I'm talking about a true psychiatric break leading to schizophrenia. That is not my opinion. That is fact. Those mental health diagnoses are lifelong diagnoses. So that's not my opinion. That's just fact. Managed in various ways. Generally, medication is going to be a part of that regimen for the most part. There are always exceptions to every rule, but the rule is generally going to be that. My Facebook page is Cassandra Barnes RN for registered nurse. And Instagram and other places. I provide therapy from several different platforms, and I have several different contracts. But Psychology Today would be a great referral source for me, and then I would direct clients to appropriate platforms should they request therapy. So it's been a great conversation, and as always, I enjoyed it. We have to do it again soon.
Yeah, and we are going to do it once a month, Sunday once a month. We have our mental health show, and we're going to continue. And I hope to have all of you on again so we can continue. Dr. Nelson, please give us your final statement about whatever you would like to share. You could talk about paranoid schizophrenia if you want to, or whatever you would like to share, and your information, whatever you would like to give.
Thank you so much, Rudy. This has been a pleasure. Yes, just a quick to kind of piggyback on Ms. Barnes in terms of delusions, hallucinations, schizophrenia, dissociations. When we talk about a scientific diagnosis, when a child is severely abused, it changes the trajectory of their brain. It changes the order. It changes the plasticity. It really, the person is not who they were supposed to be. So there's something else. They are someone, and they don't even know that. So it really is a chemical, hormonal, biological effect. And that takes it, again, medication, it just calms the brain down enough for the person to just associate, just to have conversations. So we deal with family systems therapy because this person is in relationship with people. So they have to know how to care for this person. The person has to learn how to care for themselves, just like someone who's on the spectrum or autistic. Your brain works differently, and you got to learn how it works. Otherwise, so we teach, body awareness, when you're getting upset. How upset are you? Are you nervous? Are you shaking? Are you warm? So they learn how their brain works, and you manage that. You know what it takes to calm down. You know you know that you're getting overstimulated. So with my clients, we work with making sure that their environment, not too cold, not too hot, not too much light. Everything that comes in through your eyes, through your ears, through your mouth, right, is going to affect you. The environment, the pollution in the air, the environment, the relationships they have. It's so many different components. But once they learn how, again, medication is, as much as people say, well, I don't want medication, medication is necessary because we're dealing with a hormonal chemical imbalance that can't be talked through. I can't talk to my clients who are hallucinating. They can't hear me. So, as much as I don't like medications, we just have to find the right, cocktail, as they say, because some of my clients will react one way on Zoloft, and I have another client that will act manic on Zoloft. So I work closely with the pharmacist, with the NP, the neurologist, the PCP. I work closely with them with my patients because I want to know, what are they taking? We work closely together. And I always teach my clients to listen to your body, pay attention. So you're aware of when you're becoming over anxious. Because once I always tell my clients, you must know where you are between 1 and 10, 10 being the worst. When you feel yourself rising, if you don't manage it and catch it somewhere at 4 or 5, it's going to keep going. And then people are off the chart. And then we're talking about panic attacks. People snap, right? Blackouts, fainting. That's your brain letting you know it's overload. It cannot handle everything that's happening. How do we manage that? You have to do it chemically because they can't talk themselves through that. So just want to add that piece. It is a lot about the subconscious mind. I'd love to have a conversation about that. That's very deep. In diagnosis, absolutely. Oh my gosh, I'm with you. I don't diagnose bipolar just because the first time I see you, I do just a kind of general adjustment disorder diagnosis for your insurance. But then we'll go deeper into what you are. Because again, once a person hears a diagnosis, they become what they've heard. I don't want them to hear, because sometimes I have clients that come to me, they've Googled what they stay off Google. And I said, well, I'm bipolar and I need you to help me. I said, first of all, we're going to wash out bipolar. I don't want you to put a label on yourself. Let's just talk about your symptoms. Let's talk about what you're thinking, what you're feeling, what you're doing, your actions, right? So again, great conversation today. I love for us to do this again. I am on Psychology Today, thriveworks.com, Google, and now I'm on Barnes & Noble. So you can go out there and find my book. If it's in your head, it's in your house. It is on Amazon, Barnes & Nobles, Google Play, something or whatever they call that. So yes, thank you so much. This has been a great conversation, and I would love to be a part of this ongoing.
Well, thank you. I'm going to be in touch. And let me make sure I say your name, Dr. Jaqueline Nelson?
Jaqueline Nelson.
Jaqueline Nelson. Okay. Blessings, and thank you very much. Sister Jennifer?
Yes, sir.
Finish us out.
Okay. Well, I did, I feel like we got off of the crisis piece, and that's what I thought we was talking about today, which I know the conversation does change, but that's where I would like to revisit as well, because what we talked about was the impact of certain physical crises and diagnoses, but not necessarily crisis intervention or examples of what crisis is. And that's what I thought we was going towards. So yeah, I would like to talk about that as well as continue the conversation about what we've been talking about today. I think also some of the questions, they change for different persons that are speaking, and we have different responses. So I'm going to support you in what I said in regards to how to speak to your family member. And that's what, with that support, that I would suggest. Because again, relatability and being heard and understood and not judged is the biggest start to healing. So then that person may be willing to move towards whatever it is that they need support with. And acknowledge that it's a problem too, if you are a safe space to give it to, and then you can guide them to getting the help that they need. Okay, so that's what I want to say about that. I can be found on adorncounseling.com, my website. You Google Adoring Counseling or Jennifer Cain, Jennifer J. Cain, actually, because there's another Jennifer Cain in Houston, Woodlands area. But, you can't miss the purple hair. Either way, I can be Googled or on my website, and that's the direct way to contact me, Adoring Counseling.
Well, thank you very much. And I heard you on the conversations and how they can be helpful and where to go. And we're going to talk about that. And we're going to have our next show, I believe July 21st. And we're going to formulate that particular show in the best way. I may be texting or emailing all of you to get input on how we need to design the show, because this is so important. It's an area that we need to talk about. Believe it or not, everybody comes across some mental health aspects that they have to deal with. They won't admit it. I just admit it. And I'm open about it. And I've come across it so many times. And to tell you the truth, having this format, and I do 3 other shows, these things have helped me greatly to build my own self-esteem, my own mental health, and to be able to help me grow. And so those are some of the things that I'd like the audience to hear. And we're going to continue these conversations. Mental health is an aspect of life and is something that we need to put at the forefront. I thank everybody. Anybody got a last word before we go? We have talked a long time, and as Brother Time said, we could talk about it all night, and we're going to continue. We're going to continue Sunday once a month, as I said. The next show, July 21st, and we're going to talk about mental health, and we're going to design what we're going to talk about. Anybody got a last word? Cassandra?
I am good. I am good. It's been great. I'm not trying to cause no confusion or controversy with anybody on the show. I just come from a strong background, and I come from a place of education in my experience. So it's not ever meant to challenge anyone. So
I don't think anybody took it that way.
Well, that was the energy that I felt like I was getting back. So that's never my thing. I'm highly educated, and I come from that place when I answer questions or contribute.
And we certainly appreciate you coming on.
That's my thing.
Sharing your wisdom with us every time.
To bring no negativity.
And we look forward to your next time.
Thank you. This is
all right. All right. Hey. This is Minding Our Mental Wellness. I'm Baruti Carl Alexander. Thank you. We'll see you next time.